Bonjour à tous.
So hi everybody, and thank you so much for being with us, for those of you who are live with us and those of you who are following in from a distance. And we'll be talking about how we count deaths in France today. And I work... I need the name. So I am Céline Casero-Schoenemann, and I will be presenting today's session with Bernadette Gergonne. Hi everybody, I'm Bernadette Gergonne, and I am an epidemiologist, and I work for the Armed Forces Epidemiology and Public Health Center, and I am head of department for investigations and for monitoring. And I have been kindly invited by my colleagues from Santé Publique France because I've done a lot of work on mortality. We put together a European project a few years ago on the weekly monitoring of mortality rates in Europe, and it's still up and running. It began back in 2007, 2008, and it was a great memory because I got to work with colleagues who are present here. It's still up and running, and I think it was very useful, and it's something that we will speak about during the course of the presentations this afternoon. So thank you very much, Bernadette. The session today is intended to be educational, so it's supposed to be a means to decipher the way we deal with the mortality data today. And there are two parts to the discussions. We'll be focusing on how we count deaths, and that will take us through to a break at 2:45, and then we'll give you some examples, some illustrations, speaking about the experiences that we had with COVID-19. And counting deaths, where do we begin actually? It starts with the writing up of the death certificate by the physician who takes official note that somebody has died. And during the course of this afternoon, we'll look to see how the certificate is then sent on. Who is it sent to? How is it made use of? What are the codes that are used? What organizations and bodies have access to this? And how do they use this as a basis for statistics? And we will have, we'll look to see what's happened internationally, and especially based on the experience with COVID-19. So this was coordinated by Anne Fouillet, who is a long-standing colleague of mine at Santé Publique France, and has been prepared with our colleagues from the INSEE, the CPDC, and I'd like to thank my colleagues for all their contributions in helping us to organize the program. And there's a live broadcast. There's also a simultaneous translation into English, and you're welcome to ask questions either from the room or remotely via the chat. We'll be receiving questions on our tablet. And so I'd now like to hand the floor to François Clanchet, who is a statistician, and he's headed a project to overview a project, and he will be giving us a panorama of the different sources used to determine mortality in France. So he was in charge of a project designed to overhaul and renovate the statistical processes for causes of death. So thank you. Hi, everybody. Thank you for organizing. Thank you for having invited me. My name is François Clanchet. I'm a statistician, and today I work for the DRES, the DRES, and I hereby declare that I have no conflicts of interest relative to the subject I will be talking to you about today. So what are the sources we have? And how do we know how many people die in France? So there's several types of sources. So we're going to begin with what we refer to as reference data. This is what we'll spend a lot of our time focusing on this afternoon. That's the data that is regularly published in a very complete way by our public statistical department. So the first source is a historical source, which are the civil records. And over the last 100 years and even more, we've been counting the number of deaths thanks to a mandatory registration of every death by our civil records department. And INSEE registers the deaths for administrative reasons, but also for the purposes of its statistics. And all this information is made available to the greater public, as well as to Santé Publique France. And so they count the number of deaths on the basis, and we divide it into age, sex, place of residence, as well as the place where the person died. It's an approach that has been recognized and internationally recommended, notably by the UN, to measure developments to a population and the developments in terms of demographics. The downside of using this source is that we don't have any information on the cause of death. We know that somebody died, but we don't know why that person died. The second downside is that it takes time to produce. You need to wait a couple of weeks or few months to get a hold of the data, something I'll come back to in a moment. And then the third limit is that we have very little socioeconomic information about the person who is deceased. We don't know what their social group is. We don't know the history of the person. We don't know what their status of their health was before they died. And so the information is complete, it's public, but it's quite poor in terms of details. Another source that we have is the source that we refer to as causes of death. This is going to be a very quick presentation because after my speech we'll talk about this more in detail. But this is also an old source that's been around for several decades. It's a complete source. It's based on the medical section of the death certificate, which is drafted by the physician, and it's produced by the CPDC that belongs to INSERM, and it's something that's produced every year. And so what are the upsides? What are the advantages? Here we do have mention of the cause of death. We have all the causes that have been measured by the certifying physician, and within the causes we can determine what we refer to as the initial cause, and all of this is done according to rules that are consistent over time, so that provides basis for comparison, as well as done according to international conventions, because the rules for coding and the categories are international. So there are a couple of downsides. It takes time to produce because the figures are expressed on a yearly basis, and once again there's a lack of social economic information about the deceased. So alongside these two major sources for public statistics, we also have other sources, other additional sources that very often are included in public debate and are complementary. And so these come from healthcare system. And so one of the first sources, for example, which is used quite a lot, is the source of people who died in hospital. It's the PMSI. And any hospital admissions are coded and recorded. Every time it ends with the patient dying, then it is registered as a death. So every time somebody dies in a hospital, we know about it very quickly. We don't necessarily know how the person died, but we know why they were in hospital in the first place and what type of treatment they were receiving. And as such, that's also a good source of information. There's a lot of information. That's an advantage. We know the treatments. All hospital deaths are recorded, and over 50% of deaths today in France happen in the hospital, and it's the production is regular, whether there be crises or not. However, the downside is we can't trace anything that happens outside of the hospital. It takes there's some processing time. By the time the information is flagged from the hospital to the relative bodies, it doesn't list the cause of death in the source. We know why the person was treated, why they were admitted in the first place, but we don't know why they died exactly. And of course, once again, no socioeconomic information. We only have the person's age and the person's gender, and that's all. Another source of medical origin are our emergency responders, all those who are in charge of dealing with patients sent to them for an emergency, and sometimes have to note a time of death, unfortunately. These are sources that are linked to the networks called the SOS Médecins, SAMU or SMUR. Those are the ambulance services. And these are very responsive. An emergency service, they can see when somebody dies straight away, and the information can be flagged very quickly. There are different places of intervention. There are people who die at home or out in public spaces or in retirement homes or old age homes. This wasn't the case of the other systems. And we also have individual information about the person who has died. However, what we are lacking is a detailed cause of death. The data from the ambulance services today are centralized and then flagged to Santé Publique France. But this isn't the case of the emergency services, the SAMI. And so it doesn't cover everything that we need today. And once again, we still don't have socioeconomic information. Another source that we make use of are the systems that have been set up for crises. These are systems that have been introduced to deal with extraordinary events. And they tend to be specific to a specific situation or a crisis, but they are responsive. They're made for this purpose. And things move very quickly with these systems, and it resonates with the greater public, and so they are very interesting. And if you need to adapt to a crisis, even if you are quick acting, sometimes it takes a couple of weeks or a couple of days, but these systems tend to be costly. Because some people have other tasks on the go at the same time. They have to fill out forms in a system, and so that could be a bit problematic, especially if you're facing a crisis. It's not always complete, because sometimes things can be overlooked, things can be wrongly filled in, and it's not sustainable or comparable over time. When you have a specific crisis, you can ask a person or a team to make a specific effort, but that effort is not sustainable. It won't carry on for a long period of time. And so the sources of medical origin come with certain upsides, but they also have their limits. And then
vous avez un certain nombre de données qui ne viennent pas en général
sources of data that don't come from the medical world, but are once-off. They're not sources of data. They tend to be once-off. And so these can be signals that are given, and so these aren't sources that are accounted for, but these are they can be useful, notably in light of a sanitary or health crisis. And so they are the alerts that come from the world of health itself. So when you have a professional medical group, and all of a sudden they notice that there's a sudden increase in the number of deaths amongst their patients, this is something that we find particular amongst those working in ER or GPs. And so you could have a representative of a professional group that raises the flag and says, I don't know what's happening, but it's been the last few days, the last few weeks, I've seen a lot more people dying. And the advantage of these signals is that you can do this quickly. You don't have to have a formal setup for them. They come up all on their own. They're independent, so you don't need ministry involvement or administrative involvement for the signals to be given, and that's something that's important too. And the message tends to be very simple. And so you've got ER physicians that say, okay, we're observing more deaths, and everybody understands. And you don't have to say versus the prior precedent, this is the source. It's information that's flagged very quickly. The downside is that it also depends on a lot of informal organizations, and you're not dealing with researchers or statisticians. They're people who are raising the flag because they're seeing something happening. You can't always quantify and say how many surplus deaths there are, how many extra deaths there are. You can just say that there are a lot. And these are not signals that are sustainable, and you cannot compare them over time. So these are signals that come from the health world and healthcare professionals. They can come from the funeral parlors as well. And this is something that we experienced, and I'm sure you remember as much, when we had the heat wave during the summer of 2003, and when we had some winter epidemics. And in that case, it was professionals, and these were the funeral parlors who raised the flag saying, well, we're a lot busier than usual, and this is not something that we're used to. And so they were able to flag a message, and once again, independently, independent of the healthcare world or the healthcare organization. So it's a system that's very flexible and very simple, with messages that are easier to understand for the greater public. The downside is that there's no consolidation. You don't have a central body. So you can get messages being flagged by one place and not another. There's nobody who's in charge of the production of this source of information. It can happen at a regional scale. It can happen at a national scale. And there's no information, once again, on the causes of death or on the type of victims. And so it's information that remains very simple and plain, but it does alert us as to the existence of a phenomenon. So in conclusion, in order to measure death and mortality, we have several sources. All of them have their advantages and their downsides. They have limits, but they also have strengths, and they're complementary to each other. And so there's a convergence of messages. They don't always come in at the same time. They don't always seem to be saying the same thing, but in general, they do make sense with each other. There's a consistency consistency. However, there are two limits. So very rarely you have everything straight away. Very often it takes time to get in a lot of information, or sometimes you get a little bit of information coming in straight away. And then the last downside, and this is something I've said several times, is that these sources don't have a socio-economic determinant. So we know very little about the social background of the deceased. We don't know what their lifestyles are like, their life experiences are like. And so we need to have additional operations to enrich the data. So that brings me to the end. And what I suggest is I'm going to hand over the floor to Sylvie Lamines, who is in charge of one of these sources. And then we'll hear from Elise Coudin, who also oversees the first source I told you about earlier, and that's how INSEE counts the number of deaths, and the CDPC system, which falls under INSERM.
Merci, François.
So thank you very much, François. And I'm Sylvain, I'm in charge of there is Sylvie who's going to give us the first part of the presentation. There'll be two of us, actually, because to illustrate what François said, we have complementary information. So we've got Sylvie Lamines and Elise Coudin. So we declare that we have no conflict of interest in relation to the subject, and we know that the writing on our slide is very small. So in introduction, we'd like to tell you about how information circulates when people die, starting from the certificate of death, but it's more complicated than that. We'll look at what information is flagged to the different organizations, notably the CDPC and the INSEE. And I just wanted to mention 3 points in the introduction. The first is that not all organizations have the same needs, and so that will be a condition for the type of information they receive. On the INSEE, we use this for statistical basis as well as to establish the demographic balance sheet for France, as well as to serve as input to our national register of the identification of natural persons, which I call the RNIPP. And on the INSERM, they follow up on the causes of death with statistics on causes of death. And that's a fundamental indicator because it enables us to follow up on the major causes and trends on mortality in France. And it also helps us to guide us and make assessments which determine policy. And so all of these come from the same source. It all comes, somebody dies, there's a physician that takes official note of the death and establishes a death certificate. And then after that, there are many documents that are drafted. I'll come back to those in a moment in detail. And because the final purposes are different, and sometimes they come in electronic format, sometimes they come in written format, and so there are different channels to transfer and transmit these documents. And like François Clanchet was saying, not everything comes in at the same time, and so it's very important to keep this in mind, especially when it comes to keeping an effective health watch. Now, when a death is certified by the ODA, there is the general code for local authorities. It says that any death has to be the subject of a death certificate filled out by a physician. And this certificate is required to close the coffin. There are two parts. There's an administrative part that mentions the identity of the deceased and is then sent to the city hall and to the funeral operators, the funeral parlors. And then there's a medical aspect, and the doctor will declare the cause of death. And this is then sent through to the INSERM, who is in charge of feeding it into the database, whereby they mention the causes of death. And so what's important to note is that the information on causes of death remain confidential, and INSERM doesn't receive any information about the name and the surname of the deceased. And another point today, if you're able to read the small writing, is that the death certificate is supposed to be sent through in electronic format. This has been in application since May 2022, and it's mandatory for deaths occurring in hospitals and healthcare establishments. But this is only the case for 39% of deaths today.
So digitally means there could be transfers and all that, and create two of the same copies, and that's a problem. So in 60% of the cases, doctor certifies the death on a paper form, then sends the administrative section with the medical section that's sealed, so to guarantee confidentiality, to City Hall. Then after City Hall, that goes to INSERM. The medical section goes to that, but that's through the regional health authorities. So here's what it looks like. You don't have the link there, but this is, if you're remote, you can see this link here. But you can see it doesn't cover the first name and last name. However, you have the town, the date, the birth date, and gender, and then it's hard to see this, but you ask the doctor on this request the cause of death. It's an international standard. So there's coding of the cause of death, and this can be presented and specified to you in the upcoming presentation on the concepts and the coding. And then now here is the administrative section, and this includes the marital status and the birth and data of, this is the doctor sends this then to City Hall. And then what happens at City Hall? Here we are now at the City Hall, and what happens here is there's a death certificate, or first of all, the civil document, the civil record, and that's established by a ministerial officer, and that can look at the death certificate, but it's not always the case, not required, and then they would write up the civil record based on the information gathered by someone close to the nearest of kin to the deceased. Okay, once the civil record is drafted, then you have two bulletins that are two documents that are, there's a death certificate. This is B7, and that is for statistic reasons with the socio-demographic situation of the deceased. And then B7 bis, which is the death certificate, which has the same statistics, but also includes, and this is the difference here, otherwise it would be exactly the same documents. This includes the name and first name and last name of the person. This then can go into the RNIPP repository that I mentioned earlier. So here's a copy, here's an example of the B7 and B7 bis bulletins that you can have on the INSEE website and perhaps on other websites as well. Specific information on the town where the death occurred, and a whole host of information on the deceased, their age, their place and date of birth, the gender, socio-demographic characteristics, their marital status at the time of death, profession, or previous profession if retired or unemployed. And since 2023, January 2023, you have the address where the person lived. You used to just have the town, but now you have their precise address. And then lastly, you have information on the place of death, be it a hospital, retirement home, or in the person's home. This is all summed up here in this diagram that shows you the whole circuit of information with the transfers that are documents, and those are solid lines, and the dotted lines are digital transfers. Just to look at the time frames, though. It's not practical to not have a pointer here, unfortunately. So the thing in green, going from City Hall to INSEE in the green there, that's information on the deceased to INSEE, and it's digital in 95% of the cases. And this is what, it takes 7 days, and that way you can we can track mortality for all causes. And then on the left there, in dotted lines, that's a bit more more complicated. Doctor certifies. When they certify electronically, then the medical files come into INSERM about 4 days' time. And if they're paper, they're hard copies, and they go to digitalize the ARSS and the INSERM, it takes 4 months post-death. And so sometimes it can take even longer. So for a reactive analysis for cause of death, it takes a long time. It's very complicated. In addition, this circuit, because the timeframes are dependent, people who die in the home, in their own home, they're paper certificates. People in the hospital, they die in different ways, let's say. This data is hard to process because there can be information loss, and it can be documents that get lost. So it's hard to come up with the same numbers. Now we're doing this with we're working on a synchronization phase. Next slide, please. Can someone please advance the slide for me? Okay, slide is stuck. Bear with us a minute. Okay, I'm going to give you the synchronization, but it's going to be tough without my slides. I think we're stuck here. Okay, so synchronization is to ensure coverage, make sure that we have... Can you please move the slide forward for me? Okay, it's moving forward on the tech guys' computers here, but just give me a minute. Okay, I'll go ahead and do it without slides. It's not that big. It's not that important. But okay, synchronization between INSEE and INSERM. We have to make sure we have the right coverage. Make sure we have the exhaustivity of the information. It's getting to the right place. Make sure we don't have redundant copies, and ensure that certain variables are filled out, and ensure that certain socio-geographic and demographic variables. Just keep in mind that in the synchronization method, INSEE, which has the first name and last name, they can immobilize and they can get the RNPP organization. However, the matching, say, between INSERM and INSEE deaths, this can only be done on the only common variables that I listed a moment ago: date of birth, date of death, and place of death. So, and then little by little, then we can remove the constraints to be able to get the number of deaths. So what does this enable us to correct? Well, we get the percentage of deaths where INSERM doesn't get it from medical doctors. And INSEE gets at 0.2% deaths where they've not received information yet. And so in all, that means we get 98% of all deaths recorded in INSEE, and then there's a matching counterpart of that with the cause of death at the INSERM and CDPC section. Back over to you. Quickly then, we wanted to talk about what we do with the data that we just presented to you. So at INSEE, there are 4 main uses of that. We talked about the first one, that's filling in the RNIPP repository that's synchronized. It's synchronized every night with information coming in from the French NHS, Sécurité Sociale. In this way, there's no paying out benefits to people who are deceased. And it's also available on the INSEE.fr. There's a name-based file of people who have died since 1986, and that's really interesting for genealogy. But anyone and everyone can consult that. It's not for statistical reasons. And third use is statistics, standard statistics used by INSEE. That's tracking mortality, tracking deaths, characteristics of the people who are of the deceased, and then with some results that are aggregate number of deaths every month are published on the site. Yearly data as well with the tables and indicators, and we get the demographic information on France every year, and mortality indicators, mortality rate, life expectancy. see. So all of this civil record data, this feeds into a demographic panel. This is a constant permanent demographic panel. So you can go further in analyses, studying differences in, say, life expectancy based on social category, degrees, and all that. We'll get back to COVID, though, in a minute. I think we have to stop here if we're going to leave time for everyone else to speak throughout the afternoon. Well, give us just 30 seconds to wrap up, though, if there are no questions, because we're really... So here's some causes of death and what we do with that. So this is sent to the Eurostat, WHO, and then into the national health data systems. Because this is source data for SNDN, and you can take a look at that. You can look at the time frames for dissemination, for publication, and then you can get the health journey of these people. And if you can perhaps get some 87% of the cause of death, you can compare those with their with the health journey, health pathway that they've taken. And when looking at our current projects, and this is improving the SNDS, new certification, CDRCC, that will include the synchronization. We talked about the address, and then CPDC. We have a dissemination data timetable. CPDC being a part of, actually in a catch-up phase for producing cause of death, and for 2018, 2019 are expected in July. So the final data, and that should be by when we get back from holiday in September.
Merci beaucoup à vous, Sylvie Leminez.
Thank you very much, Sylvie Leminez and Élise Coudin. We'll have a longer discussion, Q&A session at the end, after the break, but we can take one quick question.
Si vous voulez bien vous présenter.
The gentleman in the back, please give us your name. Sorry, I can't hear the question.
Bonjour, Olivier Retech.
Hello, Olivier Retech. I'm an epidemiologist in Franche-Comté for Santé Publique France, near Dijon. And as regards to requirement to have the electronic death certificate, so when people are out there in the regions, well, we're working with the regional health agency and other establishments to move to an electronic certificate. But I was wondering if on your end, if there are national projects to, as it were, encourage or provide incentive for people to do that. Off mic. Comment is off mic. Well, we're implementing the new CNPCC application. So that was to encourage electronic certifications. So it's now required for hospitals and healthcare establishments. It has been as of May 2022. So there's a definite plan that's with the DGS behind it to facilitate the connections there. Now, where does it stand? How's it going right now in practice? I'm going to hand over to François. Well, thank you for throwing that hot potato at me. Or, as it was said, it's a work in progress, and the obligation is there, but not everyone does it yet. It's moving forward. The General Health Ministry has mandated in every region there's a body in charge of electronic certification, and people are working on it. There's some progress still to be made, but it's for the regional divisions, the regional directors of the regional health agencies to work on this. However, the regional directorate of health authorities, in fact, is working on getting information from the regional agencies to figure out what's not working, what needs help, how we can improve the applications for this to work better. We've gotten started. There's some dialogue, there's some back and forth to, at region after region, try and make this systematic and make this become a reality. Thank you very much for these clarifications. We'll have a presentation at the end of the afternoon on more certification.
Thank you very much, everybody. Hi, I'm Diane Martin, and I'm in charge of the production division at the CPDC, and I'm co-presenting with Zina Ebash, who is in charge of the coding team at the CPDC. And we're not going to focus on figures, but we're going to tell you about what we do within the CPDC and how we process causes of death on the basis of medical data. So we're going to try and explain how we code causes of death. So a couple of concepts. It always starts with the medical section of the death certificate. That's our main source of information. And Francois told you about this. This is where you can find the cause of death. This is where the certifying physician will handwrite the cause of death. And then there's a block for additional information, which provides for additional information that's important for the coding that's done. And so there's also a separate section for adults and for infants when infants die at an age younger than 28 days, in which case there's a block for additional information. So a couple of definitions. When you code, the idea is to determine the initial cause of the death as defined by the WHO. It's an illness or a trauma that triggered the morbid development which led directly to the death, or circumstances of an accident or violence which led to fatal trauma. And talking about multiple causes, when we say multiple causes, these are all the causes of death that have been filled into the medical section of the death certificate, including the initial cause. We can also talk about associated causes, in which case it's all the causes of death that have been filled into the medical section, but without mention of the initial cause. Then there are what we call the cause point. This is the text which is drafted by the physician under causes of death, and we'll talk about the nosological entity, description, cause of death, and the diagnosis entered by the doctor on the medical part of the form. The morbid process is the causal chain of events that led to the death. So these are all the events that occurred and that led to the death, as is mentioned in the medical section of the certificate. And it's said that coding of cause of death is allocation of ICD codes for each nosological entity and identification of the initial cause of the death according to international coding rules. And this is to give an example of the morbid process. We go back to the medical section where it says causes of death. This is part 1 of the medical certificate. And so the certifying physician will have to fill this out, and he'll have to write the immediate cause that led to the death on the first line. And then he will indicate what caused the immediate cause. And so there's a whole, he'll go all the way up the causal chain of events. So on line A, there'll be brain metastasis, which was the result of a cancer, for example. So there can be 2 lines. And so once we've received the medical section, then we'll institute the coding process. And so starting with the causes as they appear, we'll have causes for each of the mentions on the certificate. And then we will go on to identify the initial cause. We've got validation processes and verification processes. And this is all entered into the database. So we'll code according to the International Classification of Diseases, version 10. There is a part of the causes which is automatically coded progressively. So we have an expert system. So 63% of certificates are automatically coded. And more recently, we now have introduced AI, artificial intelligence, with deep learning algorithms that fill in certain parts of the certificates on the basis of past data. And the rest of it is manually coded by a team of agents within our team. So if we look at the coding tools more detail, we've got our Bible. Our Bible is the International Classification of Disease, which is held by the WHO. It uses common language, which enables us to share standardized information throughout the world, so we can do both geographic and temporal comparisons. And we also have recommendations for the production of mortality data, and more specifically relative to the coding. So this is where we can find the international standard for the medical section. So this defines the content to be contained in the form. We can find the rules for selection of the initial cause, and Zina will tell you about that. Zina will tell you about that afterwards. And all of this is maintained by the MRG, which is the Mortality Reference Group, which is steered by the WHO, and we are members of that group. So another technical tool that we have is we have a software that we use. It's called IRIS, and it's used in a lot of countries, and it's maintained by the IRIS core group, and it carries out automatic coding using the expert system. And it's done in 2 steps. So the software will code all nosological entities, and so you will be the text and the diagnosis written in French, and then it will be applied to the there will be a standardization method will be applied, and then it will find the code that goes with the description. And then there's a second step, and so once all the codes in step 1 have been identified, then the rules for the selection of the initial cause will be applied. And so this is all done by the software. So it's thanks to IRIS, and via the IRIS interface, that after that we will enter any manual codes that weren't filled in automatically. And like I was telling you, from the dates of 2018 onwards, we now use algorithms, so artificial intelligence, which can also intervene in predicting the cause of death. And so this is for all associated causes, multiple causes, as well as identification of the initial cause. I'll now hand the floor to Zina, who will give you details of coding rules.
Nouveau bonjour à toutes et à tous. Alors,
hello again, everyone. As Diane said, our Bible is the SIMDIS here and the ICD, and you can see the codes are listed in the ICD-10, and that's it's very specific, and that's what gives you the uniformity of the application of the rules, and it helps us find the initial cause. So you get a little algorithm there with the rules. So we apply the first 5 rules that get us to the starting point. We have 3 other rules where we can get to the initial temporary identified cause, and we have 4 other rules that enable us to reach another initial temporary identified cause. And if they're identical, well, then they become the final initial cause. And if the 2 initial causes are different, we have to go back through the whole loop again. You can see it's complex, but this is the only thing that makes us ensure of the uniformity of the coding. And this is discussed and reviewed frequently with the mortality reference group that was mentioned earlier. There's an example of a death certificate, which is filled out succinctly. As you can see, the IPCD-10 looks like hieroglyphics, right? But this is properly, let's see, cardiac arrest, line A, that's the immediate cause of death, 26th of January 2018, and then we have line B, which is following the rules, the initial cause of death. We only have the pathologies that are that the patient had, but in fact were not part of the chain of cause and effect. So here's some rules, SP3 that we saw earlier. And this is when you have a death certificate, there's only a single logical sequence there. You can find the initial cause, the lowest one there. So if it's logical, you have cancer. Lung cancer gives you multiple metastases, and then the respiratory arrest, and that could be the cause. So this rule then is applied also when it's external causes. If we see a traffic accident, for instance, or a blunt trauma to the skull, that could the initial cause then would be a traffic accident. So here SP4, this enables us to, when you have the certificate and it's filled out when the cause and effect chain doesn't comply with the standards for the WHO. Here, this is a flu condition. In having a flu, part of the morbid processus, according to WHO, we have to go find the initial cause being flu, SP5. It's because in the death certificate you don't have the chain of cause and effect. And so this we would go with the most logical cause. And it's not intuition, but it's applying the rules. SP6, this is a rule for us to find an obvious case in death here. The sarcoma of Kaposi is part of this cachexia. So you have to find what is your AIDS. Again, this would be in volume 2, and the coders are familiar with that code there. So if we also see in the second part, or the last part here, in the second certificate, if they've choked or you have the pathology, then it could have been Alzheimer's, and I've almost finished. Give me just a second. So we also have certificates where the causes are unlikely, such as we have an ingrown nail, and that's not very medical. So sometimes you have to go a lot deeper, and sometimes these certificates, the doctors who fill out the certificates, sometimes they give us lots of information on the means of death or the way the people died, but not necessarily the cause. Like the last certificate there, where just like everyone, unfortunately, people can die from, of course, a cardiorespiratory arrest. Okay, very quickly, conclusion. So that the coding is quite complex, requiring the raw causes and most precise as possible with the cause of chain and effect, the quality of the compilation of the data and certification. It requires complying with the rules of the SIM 10, ICD 10, and there's errors in coding, and we have to make sure that there are differences in interpretation, that these all get homogenized. So we have to make sure that all those different interpretations are avoided. That's why we have all these verification processes, and there's a continuous information and education they're going through in terms of production at CPIDC. We can combine these different modes of coding by targeting manual coding for specific types of death, such as neonatal or maternal or in maternity. We also have these use some artificial intelligence and to make sure that we reduce mistakes.
Merci beaucoup à toutes les deux. Diane.
Thank you very much. You can see that the point of having information, having the doctors write the cause of death as clear as possible and as precise as possible. We see that that's very important. Do you have a way when the death certificate is ambiguous or unclear and you can't define the initial cause through the coding? Do you have a way to go back to and get in touch with the doctor to get the information? And do you do that often? Well, in practice, we can do that, but as you saw, that the medical section is anonymous, so confidential, so it's really difficult to go back to the certifying physician without opening back up the case, especially if you're remote, because we have a production time that's it's not the same as it's happened there, especially in the maternal mortality, but it's really going to be on information and training, and electronic certification now will improve the situation because we can get a lot more done, and we're looking at implementing ways of interacting directly with the doctor when he's actually keying in the information to get the actual data during certification, not have to get back in touch with them several months later. Thank you for those clarifications. Any questions from the audience? Yes. Hi, I'm Bruno. I'm in charge of prevention of chronic diseases. So I can't answer a question that was mentioned earlier. But anyway, my question is in terms of international comparison and the cause of death. You have some undetermined causes of death. Where does France stand in that? Because there's some cases where you see more undetermined causes than actual determined causes. So do you have this? Well, we're right in the heart of production right now. I might let Elise add to that in terms of the numbers. I'm sorry, off mic. And there are unknown causes. Sorry, I can't make out what she's... Yes, there are unknown causes for sure. 2% of the medical reports that don't come in. So we just call them unknown causes. But undetermined causes, yes, our levels are very, very high. In fact, so yes, it definitely is worthwhile to have a European comparison. As regards coding, this was brought up in May. That issue was brought up in May, and we realized, unfortunately, then in the circumstances, I don't know if you remember in the death certificate, you can check off the circumstances, and there's a box that says undetermined, and undetermined is considered differently in different countries as that's being filled out and in terms of the coding. So we are working on that because undetermined in some countries might mean unknown. For us, it's not unknown, it's undetermined, and that means something completely different from unknown. So I'm not sure I'm answering the question, but we are working on that. We do have avenues for that. Right, thank you. Let us move forward. Now, looking at the definition of the initial cause, we just talked about. Now we're going to have a presentation on the recent trends in mortality based on the initial cause by Elise Boudin and Anne Fouillet. Well, hello everyone again. Okay, we're going to talk about the recent trends in mortalities per cause, based on cause. Now, two publications made in December, came out in December of last year, looking about the distribution and the cause of death in 2020. So these two publications in BOH, and they address results. They don't take into account the data 2018 and 2019. These weren't available yet. So the temporary data, the provisional data is available, and that's on the website there. You can see that. You have the link up there for that. So the goal of the presentation is to describe the trends from 2015 through 2020. We use national statistics, and we'll be focusing on the initial cause. Okay, now we know what that is. And from the ICD-10, and looking at the initial cause, according to the European list, we've added an additional cause for COVID-19. So these are people living and dying in France, continental France, and the overseas territories, standardized mortality rates to be compared. So if we look at the trends for all causes, mortality trends from 2015 to 2020, you can see standardized rates for the 3 years. We have all ages, men and women. We see from 2015 to 2019, there's a trend, a downward trend of mortality in 2020, an increase, specifically related to COVID-19. So you can see the 667,496 deaths, and so that's a mortality rate of 899 per 100,000 inhabitants. So was it 836? I can't really see that. And sorry, versus 836 in 2019. So if we looked at our analysis excluding COVID, it's not present here, but we saw a decrease in 2020 compared to previous years. Now, if we focus on the main causes of mortality, here you can see standardized for the main sections based on in descending order. Tumors, circulatory system diseases, COVID-19, and the main causes are decreasing since 2015 and continuing to decrease in 2020. Also for nervous system diseases, 2020, we see a drop in standardized causes. For external mental diseases, infectious diseases, we had seen an increase in mortality in endocrine-related digestive conditions. So a focus here on the two leading causes, tumors. In 2020, about a quarter of the deaths, and that's If you look at deaths by tumors, 50% these were people over 85, over 65, between 65 and 80, more deaths in men than in women, 1.8 difference. Most frequent is lung tumors, 18% of the deaths by tumors, and a downward turn for most tumors as of 2015, with the exception of pancreatic tumors. Second leading cause, we said, is a circulatory system, and that's 20%, so 5% in the older patients. Two big families. This would be ischemic cardiopathologies and strokes, 23% respectively of deaths in 2020. And we can see on the two graphs here, underneath the ischemic cardiopathologies, the standardized rates are much higher in men than in women, and the variance is less distinct than for cardiovascular disease. And then after the trends, then a complete break in everything, COVID comes in, so it's the third leading cause in 2020, with 69,000 deaths, so over 10% of deaths in 2020, as many equal men as women, with excess mortality for men, amongst men in comparable ages, slightly higher than the excess mortality for other symptoms. So we saw this with the mortality quotient from Natalie's presentation. Elder patients with comorbidities and complications that are more frequent than in the general population, particularly in the younger victims, where we can see respiratory illnesses, circulatory illnesses, diabetes, and tumors, obesity for the younger patients. So a breakout of the deaths, COVID-related deaths, with more frequent victims in the regions that were, of course, hit hardest by COVID, Grand Est, Rhône-Alpes. And here you can see annual breakout here. In the epidemic peaks, the number of deaths, number of COVID-related deaths is about at the same level as the number of deaths, traditional habitual number of deaths from cardiovascular diseases, and so relatively close to tumors as well. So another point here is external causes. This is the fourth leading cause of deaths. So this is 6% of the deaths. We're not talking about the undetermined ones, okay? So this is mainly accidents, falls, that in fact impact women more than men, and that's related to age. And let me also stress suicides here, because this is particularly of interest here, with the mortality rate in 2020 was at 14 out of 100,000 inhabitants. If you look at the numbers in 2017, it was 13.4. If you look at since 2018, there's a new model of certification that helps you better note down suicides by using additional information. And Zina and Diane mentioned that, so they check off that specific suicide box. And then the CPDC-10, IC10 has improved their coverage with the forensic physicians in Paris, and that has an impact on the trend, and including these new certification models not happening immediately with paper, whereas it's the case in electronic certification, meaning, in fact, it's difficult to compare this with current years, so it's really difficult to draw conclusions immediately. But in 2020, we had less frequent suicides during the pandemic as opposed to between pandemics. So 2020, between the break and prolongation and the continuation of previous trends, with mortality excluding COVID, 800 per 100,000, where we had 140 for 100,000 in 2019. I'm talking about this. This suggests certain explanations, a protective effect of the during the health crisis that, in fact, reduces road accidents, traffic accidents, and reduces respiratory disease deaths and infectious disease deaths when people were using the protective measures, and then when you have specifically lower rates of flu. And then there's a sort of competition effect between deaths related to COVID of, say, already fragilized and elder people who would have died anyway that year, perhaps from a different pathology. And then the continuation of the trend of the drop in mortality, quite simply. So European comparisons here, looking at the Eurostat databases on causes of death across Europe. The fact that the COVID deaths be higher than the death surplus that we see in 2020 in France. This means, okay, you also see this in the other countries mentioned here, Belgium, Luxembourg, Netherlands, Sweden, Denmark, Spain. So France is actually, with the mortality or COVID-related mortality rate, is about in line with the European average. Also, things that still hold true. France has the lowest mortality in all causes across Europe in 2020. And that is connected to our life expectancy. And Anne presented the first part that tumors were the leading cause of death. And this is something we see also in Denmark, Ireland, Netherlands as well. And I think that in the UK as well, but they're not in Europe anymore. So we don't have their data. But in these cases, now, but other European countries, it's circulatory diseases as the leading cause. Now, in conclusion, what was presented is based on provisional data for 2018 and 2019. So let me just again mention that you'll see the final data in July. At least that will then be for the Eurostat data, and individual data will come later. And something also, you have to think about the break-in series to interpret the trends in external causes over the past few years, as we talked about. Suicide, for instance, in 2020, all of this information, everything is going along the trends. We don't see any real macro effect leading towards effects that can be quantifiable and additional deaths being related to taking them into consideration, taking later time. So this time, taking more time to do that. So these effects come up later. We will then analyze the data for the year 2021. And then lastly, before handing over, these are contributions. So this is a list of the people who contributed to producing and analyzing this data, and we would like to thank them all.
Merci beaucoup.
So thank you. Does anybody have any questions? So you were obviously very clear. We have one question. Hi. In terms of medical causes of death, there were certain years that were missing, or your data is provisional. Is this information that's available to private individuals, or is it only at your level? When you connect to the Eurostat database, it's called Cause of Death Eurostat. That was what I used to compile my slides. But anyway, there's that database which contains all the provisional data with the number of deaths and the mortality rates. With a categorization by cause. And so it's according to the recommended European shortlist. And so we can have access to that. Yes, you can. And individual data is a good thing because when you talk about individual data, so it's going to be handed to the SNDS in October, and that will be the final data. So the final data for 2018 and 2019, we will do the stats for Eurostat and deliver them in July. And in September, October, we will then send through the individual data as input. Any other questions? So I'm Gregory Laillet, and I'm an epidemiologist for Santé Publique France. I'd like to take this opportunity to thank you. I've been using data from the SNDS, and I realize there's been a lot of efforts that have been made, so I'm really happy that it's all there for me to use. There's something that I was wondering about when we think in terms of causes of death. And so, for example, you used Alzheimer as an example, dementia, and that could be thought to be an initial cause of death. I have worked on dementia, and when I was in the clinic, I didn't really come across a lot of deaths, but you used an example of somebody choking and they have dementia. And so I wouldn't have written up dementia as the initial cause of death. And we usually identify cardiovascular causes. And so if there's a lung embolism, that will be the initial cause if I do it. But if somebody has a cancer, then their initial cause will be cancer and not the embolism. And so I'm just wondering what really constitutes an initial cause. Well, I'll start giving an answer, and then I'll hand the floor to Zina, because it's a question that she's well versed in, but it's a really interesting question. And it's interesting that this comes from an epidemiologist. And it's the way doctors are used to filling in the initial cause and the process, and their understanding of the process, that has an impact. And there's a lot of work that remains to be done. And that means that the coding work means you have to have perfect knowledge of the ICD and the coding rules. And so that isn't something that falls upon the physicians, but that falls upon teams like Zina's team. So thank you for that great introduction, says Zina. And the examples that you've just given are exactly the type of things that we focus on. So there's the person who choked, but the person happened to be suffering from Alzheimer. And so what we apply are coding rules and not medical rules. And there's a difference. And it's even written in volume 2 that sometimes we make decisions to find the initial cause. I come from a medical background, but it can be contradictory to what we would usually state as an initial cause. And so the way you feel about things, it's not something that works very well for statistics. So if somebody has a lung embolism, and if you have the lung embolism, I think it boils down to how the doctor filled out the certificate, the morbid disease process that was identified. It depends on your age. It depends on a lot of things. But there are coding rules that need to be applied, and they're strict, but that's just how it is. And that's what makes us more or less standardized in time and in space. And I think that look at volume 2 and read it, especially if you're working on a specific type of pathologies and diseases. And as a coder, I encourage you, insofar as possible, to always look to see what all the other associated causes might be. It entails a lot of work. It's not always easy, but I think it's very interesting for certain cases. For a lung embolism, for example, you could have a post-operative pulmonary embolism, and then when you're trying to find the initial cause, you'll look to see what happened during the operation. You can have a pulmonary embolism for many reasons, and it's not necessarily the initial cause, but it could appear on the medical certificate. So if you have the possibility, you also need to see what the other potential causes are around the initial causes. So don't only look at the initial causes, but look at all the associated causes and look at all the texts. So thank you very much for the question, and thank you for those answers, because this is a perfect introduction to the next introduction, where we'll hear about the analysis of multiple causes, and presented by Aline Dekel. So that's the perfect transition. And this is a good opportunity to encourage you to use all the causes mentioned on the certificate, as well as to apply different rules. The ones that are given by the WHO have another intention, and that's one of public health care, but there can be other rules. I am a researcher at the National Institute of Demographic Studies. And I'd like to mention my colleagues from the University of Barcelona, INED, the University in Rome, and the statistical institution ISTAT. I'd like to mention the existence of a network that I coordinate that focuses on multiple causes of death, and the IUSSP panel on declining mortality and multimorbidity at death. And so we try and create links between developments in mortality and morbidity at time of death. And so the context in which we work, of course, it was affected by COVID, but we tend to try and look at the long-term trend. There has been a lowering of mortality rates. Death rates have gone down. And at the same time, potential growth in the prevalence of multimorbidity amongst the population in general, which is most likely to be involved in the processes leading to death. And so we thought it would be interesting, in addition to that, in addition to analyzing the initial cause of death, that it would be useful to develop an analysis on all causes mentioned on death certificates, what we refer to as multiple causes. I'll skip over this slide very quickly because you've already been given the definitions. So what were the final outcomes being sought? So I have identified four. The first one is to refine the description of the processes leading to death by looking to see what the combinations of causes could be. This is something that is particularly frequent on death certificates. We also take a look more particularly at multimorbidity at the time of death, and we try to qualify it socio and demographically. Is it more common in women? Does it increase with age? Is there a social gradient for multimorbidity at the time of death? We also try and look at the relationship both in time and in space. At the beginning, we started by doing international comparisons, but we wanted to see the relationship between the declining mortality and the prevalence of multimorbidities at time of death. And something else that we haven't done so much, but we would like to do, is we want to calculate specific mortality indicators according to the role played by the various causes mentioned on the death certificate. So our colleagues from the CPDC, who have done amazing work, they provide us with records, and it's a snapshot of the death certificates. But beyond the initial cause, the information isn't really ranked. There's not much of a hierarchy. And so we get the raw material, but we have to try and format it. And what we try to do, we try and create a typology of associated causes. We have distinguished three different types of causes. The causes that are the consequences or complication of the initial cause of death or its treatment. There are causes which are a factor of risk for the initial cause. And there's a third category that was spoken about by Menton and Stallard, who were famous demographers in 1982, who spoke about the background factor. And so using the death certificate, we look at the causes that contributed to the process leading up to death, either by making it worse or making treatments difficult, but are not really part of the causal chain that led to the death. In the field of public health, there are different types of things at stake. Complications and initial cause and consequence of treatment falls under what we refer to as tertiary prevention. Factor of risk for the initial cause falls under primary prevention. And as regards background factors, here it's more in the clinical field. So it relates to interaction and incompatibility between the different treatments, vulnerability and frailty, weakening, or especially the frailty of older people, and this makes the main morbid process worse, so it aggravates the circumstances. And before I give you some examples of how we analyze multiple causes, just a couple of words about the quality of the data that we work on. And the question is, can we compare the different countries? So they're different levels. There's the codification of causes. And so I'd say from that perspective, we are quite serene. We have various tools that we heard about before that have been standardized at the international level. We have rules that have been set by the WHO. And so when it comes to the coding systems, we are working with material that is quite harmonized and raises no particular difficulties. where we have more problems is more upstream. And I wouldn't even say this is a question that we ask ourselves at national level, but it's a question that's relevant even between different physicians. We all have different ways of filling out the certificates. And in some countries, you don't even have doctors or physicians certifying death. I'm sure that everybody who does this is doing their best, though. I'm not trying to point fingers. But what's required is training for the people that certify, motivation for them to fill out the forms correctly. It's also a question of literacy, knowledge. The certifying physicians need to have information about the person who's died. And there's also difficulty linked to multi-morbidities, of course, and identifying the main process that leads to the death. And in preparing the slide, I wasn't thinking in terms of e-certificates, but that's something I think that's going to make life easier for us. And there's also a question related to the format of the paper certificate. The countries don't always use the same type of certificates, the same format. So I'd like to show you a couple just to illustrate my point. This is the one we have in France, which is very much compliant with the WHO recommendations. This is a certificate they use in Italy. So even if you just look at the way it's presented, you've got blocks, right? And instead of just having lines. And that could have an impact on the number of causes that can be mentioned on the certificate. And another thing is that the order is the other way around compared to that recommended by the WHO. And I'm not behind those that certify in France, but you said that when you gave your presentation, they start at the beginning and then they go up. Or maybe they start at the top and then they go down. But the order in which you do fill out the certification can have an impact on the volume, the details, and the precision of the reported details. This is what the Spanish certificate looked like. You've got blocks similar to the Italian certificates, but still different to the French one. So there are 2 lines, for example, for associated causes. And then this is what the American certificate looks like. I don't actually have the actual size of the paper in mind, but that can also have an impact. There's very little place for associated causes, and all of this can have a role of the quality of the certificate. And you can assess the quality by looking at the number of mentions on the certificate, for what it's worth. And so here you've got the 4 different countries whose results I'll be presenting, and France, Italy, Spain, and the US. So there's green for Italy, black for Spain, US for blue for the US, and red for France. And so the country that has the fewest mentions has the most mentions is Italy with 4.3, followed by Spain, which is just in front of France, and where they have the fewest number of mentions is the US. And France, Italy, and Spain in general, their number of mentions are quite comparable. They've got quite high for the younger ages, and then it goes down, and then it goes up around 80 to 85 years old, and then it goes down again. The states are quite specific because their line is quite flat. The average number of mentions on the certificate tends to be stable, regardless of the age group. And so that just reflects differences in the way that we certify deaths, and probably just differences that we have from country to country. So let's have a look at, let's probe a little bit further. And with my colleagues from ESTAT, we developed a program, and what this program does, I won't tell you the details, but what it does, it enables us to create a ranking, a hierarchy of the different causes. So to rank the different causes mentioned on the death certificate, and using the decision-making tables that are included in their IRIS, the expert software that we use. And so there are 2 different methods, and so each cause, depending on the rules that are allocated, get a label. And so there are 3 different types of roles. And so these are things I mentioned before in terms of the typology of causes of death. And so there are originating causes, so that they're originating, and then they're precipitating. So that's the consequences of an originating cause, and then associated cause, and these are always in the second section. And there's all that's ill-defined, and so we don't really know what role it plays. It's just ill-defined, and this means that we could probe further in terms of the average number of mentions for each of the death certificates. And for the originating causes, it's more or less the same in all the countries. And that means that there's a non-negligible percentage of certificates. We have several originating causes. Where we have notable differences is on the precipitating causes, where maybe there's less of a framework. So in terms of the details and precisions given by the physician to describe the process, the field is more open, so there's more variety, and so it tends to be higher in Italy. In terms of the associated causes, there's a little bit of variation, but on the whole, they tend to be lower. And ill-defined, this is the average mentions of ill-defined causes, and Spain, Italy, and France are very similar, but it tends to be weaker or lower in the US. And so in our team, we have developed new indicators. So there are two. One that aimed at reassessing the level of mortality, taking into account all the mentions on the certificates, and another family of indicators, which is aimed at looking into associations between the different causes. And so what we call them is SRMU and CDAI. So SRMU, it's an indicator, it's a ratio. It's a standardized ratio between a mortality rate, which is calculated on the basis of all the mentions on the certificate and mentions of associated causes. And if it is equal to 1, it means that the cause is the initial cause. And this was implemented in several countries, and it was published in Population et Société. This was a publication in 2016. And out of all the countries, we calculated on the basis of SRMU for some major chapters of international classification. And so this is what you can see on the vertical axis, the points that correspond with the different families. So tumors, for example. You've got all the points that are very close to each other, but they're very close to one, versus a tumor that is mentioned on a death certificate, which is most often the initial cause of the disease. For other pathologies, and so this is what you can see in the last section. So disease related to blood or
Deuxième type d'indicateur, le cause indicateur d'association cause. Ah, j'ai passé. Bon, c'est pas grave. Je passe directement à l'illustration.
Okay, I'm running out of time, so I'm going to go directly to the next part. And we tested different graphic representations, including this one. This is France on the left and Italy on the right. And horizontally, what you have are the associated causes, and vertically, the initial causes. And the darker it is, it means that it has a stronger association. So what we can note here is that the situation in both countries is pretty similar, so even if they have differences in the certification process. And on the diagonal line, it's dark. So when there's a tumor, very often you have a tumor as the associated cause. And what we can see here as well is the association with infectious diseases as an associated cause, which brings me to another study that focused on infectious diseases, and this was before COVID, whereby we worked on people who died at 65 years and older. And so we looked at the different diseases by infectious disease. We had a whole list, not only just from chapter 1 of the classification. And so here is the list. You can have a look at it if you want. And we took into account the causes mentioned as associated causes. And so with a comparison between France and Italy. And so the bottom in blue is only the initial cause and chapter 1. And blue, red, and blue, all of it together, we go to 2% of deaths to 20% of deaths for those 65 years and over. And just in conclusion, something that's very important for me is the work that we've been doing since 2020, and that we haven't yet integrated data from COVID, but we have implemented for data from 2017. And this looks at multimorbidities that exist at the time of death. And so we've got an initial version of a classification program that we worked on, and that has since been improved. And in looking at the labels associated with the causes, we were able to make the distinction between 3 types of major major processes leading to death. And it's simple to say, but it's not actually simple to conclude or deduce. So we've got what we call the simple processes. These are one process where we have one originating cause and no associated causes. We have the multi-morbid processes. These are processes we have several originating causes and or at least one associated cause, and the rest are all ill-defined causes. And so these are the results that we achieved for our 4 countries. For the simple processes, these were standardized for 50 years and all, divided into age groups. And so the mortality rate, you can see that the levels are quite similar for all 4 countries. And depending on the age, the levels were a little bit lower in Italy for the simple mortality rates. What's more intriguing is the level of mortality for people with multi-morbidities during the time of deaths. And this is very interesting. And what's interesting to look at is the level of multi-morbidities in the US. And so we know that where US, they have the shortest life expectancy. And so more multi-morbidities at a younger age, but at the older ages, it's Italy who takes the lead. And so this was a question that was asked earlier about the ill-defined processes, and this is part of the exception. And in France, we have a higher mortality rate for ill-defined mortality in France. If you have questions, don't hesitate, because there's a lot that I can say about that, which I won't.
Des questions sur cette présentation très complète.
Thank you for that very exhaustive presentation. 15 years of research there in 15 minutes. Not bad. The question everyone is asking, okay, a couple of observations. Of course, when it's ill-defined, that is a problem. We're not happy with that. Who are these? What are these? Is it simple or is it multi-morbidity? So what we did to cover pretty much all these scenarios, we tried to put them in the multi-morbidity or break them out proportionally, and the multi-morbidity in the simple. So it doesn't really modify the diagnosis there, because you can see there's a different scale for the ill-defined, so it doesn't really affect the overall observation that we made. But that's a real issue. It's a real question. When we talk about it with the team, sometimes we say, well, ill-defined, I would tend to think that it was multi-morbidity. I mean, that's the way I saw it, sort of the inability of the doctor to describe the complexity, but that's not necessarily it. It can be a total lack of information on the death, meaning, okay, it just goes somewhere where it's ill-defined and not multi-morbidity. A technical observation, though, that needs to be confirmed. I have a bit of a suspicion that amongst the ill-defined, and not that many of them, but if you compare those internationally, it might be a matter of field. Maybe distinct between, say, France and Italy, meaning that we could probably show more information, but it hasn't been analyzed and assessed by an expert. Any other questions? We're running a bit late, so we're going to have a 15-minute break if there are no further questions. Maybe we could start back at 55. That's kind of off mic, but you can ask the speakers during the break. And if we can keep the time properly, we might have some more Q&A at the end. And we will try and answer the question that came in on the chat regarding integrating the identified cause in the EML, how those are processed in terms of data. Now we're back for the second section of our presentation today as to how and why to count deaths in France. This section is on the COVID-19 experience. Now that you know everything about certification, coding, partners who use the information, the analysis methods, now we're going to look at how all of this was used in the COVID-19 context to, in fact, track the number of deaths during COVID. So we have François Clanchet from DRES. I'll invite him to come up, and I'll be doing the presentation with him. So I'll give you a talk about, what the sources are, because François presented the sources earlier, and we'll see which ones are actually used, which ones were used during the pandemic, and what the statistics are, what the ultimate numbers are of that. So looking at the sources that were mobilized in the beginning, these were existing sources already used routinely by Santé Publique France for analyzing mortality that's produced every week, for a weekly epidemiology report. And these sources then were put online using our preferred partners, INSEE and the ICD and the CPDC in 2018, and that's based on those online. So online open data indicators for our partners, and following up the routine analysis from our partners at Santé Publique France with also electronic certification, electronic death certificate. So can we have the slides up here, please? No conflicts of interest. Forgot to tell you that François doesn't have any either, and he said that as well. So these two sources, INSEE and the electronic death certificate, first of all, what was really important there was the reactivity or the responsiveness and covering the general population for all types of death and all places of death. So these two sources were common. For INSEE, this is data that was already known and analyzed, and the methods that were presented by Anne Fouillet. Electronic death certificates, this data then includes the medical cause, and then you would have COVID on that as the cause of death plus comorbidity. So very important information, very useful information for tracking the impact of COVID. Second source, they're also being able to track, being able to monitor non-COVID causes of death. That was important information that was not covered elsewhere. However, these two sources had two main limits. That this data didn't include the medical cause of death, and so electronic death certificates, its deployment was limited, extremely limited, because there were only about 20%. We were only about 20% at the beginning of the pandemic that didn't give us exhaustive coverage. So these are two sources, relatively well analyzed, good knowledge of the strengths and weaknesses of this, but didn't allow us to estimate an impact and monitoring or follow-up of mortality rates due to the pandemic. So two new sources were created to fill the gaps here. And these were created for tracking specifically COVID-19, and they were not limited to just observing mortality. In both cases, we had follow-up for the beginning. We had the civil victim information, and then medical social data. So we were able to track people who were hospitalized for COVID and residents who had COVID in the retirement homes. So setting up Civic, this was as of the 10th of March, and that included data from the social and medical social and the retirement homes. So these two systems, the first one's based on an existing system that in fact was used for something other than its initial functions, because it had been created following the terrorist attacks in Paris and Nice, and being able to track patients in the hospital, to be able to contact the get in touch with the families based on this. So the second one is a system that was adapted from an existing system, which was monitoring respiratory illness patients in retirement homes, to be able to track these in conjunction with COVID-19. So the CIVIC is the information system for victims of terror attacks in exceptional health circumstances. So for Civic, we had very good reactivity, but a little less so for the SMS and the retirement homes, and then the ability to identify the connection with COVID-19, because patients in Civic were to be biologically confirmed or through scan, confirmed with scan imagery, whereas patients in the ESMS or retirement homes, they were identified, though they did not all have the PCR COVID test confirmation. Limits of these systems, in fact, were these were populations that were under monitoring. They were specific patient populations in hospitals and the retirement homes, so it wasn't. These were not general population sources. In all places of death, we were lacking additional medical information because we required the double input by the healthcare professionals, and so there were a number of variables. In fact, were limited there to reduce the impact of additional workload, as they were already had a huge medical and healthcare workload. In terms of the information for, in terms of Civic, in terms of information gathering over time, we had the patient with COVID, and then patients who were in there for COVID. So patients who've either died of COVID or died of an infection, a related infection. So there was some discontinuity over time. And then as the epidemic advanced, it was more and more difficult for doctors to continue this double input on the sources. Having a lack of reactivity, in fact, this wasn't used for, this was used, in fact, after the fact, a posteriori, to confirm the initial count. What it didn't say, but you can see that on the slide, previous slide, sorry, is that Civic and ESMS sources, these were used for the daily count, daily death count of COVID-19 in connection with the agency. So provisional counting our certificates, we said this is every 4 months. Lise presented this. And then the exhaustive analysis following the expert's opinion of COVID. This is from CPD, and these are the references, and these were not able to be used on a daily basis to track deaths related to COVID-19. And over to Francois now. Based on this data, he's going to give you the results. So it's good to know the sources in theory, but what actually comes out of the figures? So here you have as many figures as curves, but is the message the same? So the first graph you have here, these are graphs with the numbers of deaths per month from March 2020 to December 2022. And you can see what will change based on the curves is the source. So in the first graph, you see specific sources. The first one, top red, this was set up especially for COVID, and this was adapted to COVID. Civic in hospitals, serve ESMS in essentially for elder patient homes or retirement homes. So every evening we would get information to Santé Publique France. We would get the number of deaths, and we would input these. You see the first peak there that we all experienced as we were locked down, so 20,000 deaths in April 2020. And then you have a drop to almost zero in autumn of 2020. You have the various waves here. With November 2020, the peak, the second wave, 15,000 deaths. And then the waves that luckily started the settling down. Now the second source is, these are electronic death certificates, because it was very responsive, very reactive. You know, you understood that from the presentations that you had earlier. We could see very quickly how fast you saw the word COVID written in these, and you see COVID or no, COVID minus, COVID negative. So the first thing is it's much lower, because at the time we only had 20% of the electronic certificates. Only 20% were produced electronically, so that gives us much lower numbers. But what's interesting here is the curves are pretty much exactly the same. When one picks up, the other one picks up. So we have a confirmation here, sort of confirmation of these sources that are completely independent. They come from different places, but you get the same message, and the waves are exactly the same for both sources that are very different. So let's make things a bit more complicated, though. So here I'm going to add to that same graph a blue curve, the light blue curve, and this comes a little bit later. This is when you take all of the certificates, including the paper certificates. And if you look at this, and where we had the word COVID on the certificates, this is provisional data. Of course, we only had we would have 4 months following the given period, and that gives you the light blue curve. And here you can see it is just slightly higher than the red curve. It's systematically above, but just by a small amount. Remember, I'm sure you listened to what was said earlier, this source includes home deaths, deaths in the home. So neither in retirement homes or in hospitals, but at home. That's why it makes sense that it's a little bit higher. And see, you've got pretty similar numbers, pretty close numbers. If you look at not peaks, but entire year, looking at 2020, the death count there with that you have a 76,800, 64,000 civic ESMS, and 27,500 for the electronic death certificates. So you can see 2021, not anything but negligible, but lower than 2020, but it's the same rank order there in terms of counting. So 2022, again, lower numbers, but anything but negligible. And we're between 22,000 and 50,000 that can be attributed to COVID in 2022. So the pandemic continued all the way into last year. Now, let me make it even more complicated by adding another curve. And then things will get simpler. Hold on. Bear with me, though. Now, I'm adding in the results of the coding of Diane and Zina's team. And these are the 2020 certificates. So that's all that we have completed at this stage. So the coding, the expert coding with the COVID as the initial cause of death, you can see very, very close to the red and light blue curves. And this, it makes sense for it to be slightly under the light blue because this is just the initial cause, right? If COVID is an associated cause or a concomitant cause, it's not included here. This means that our initial counts over a few days with civic or ESMS, or a little bit later with the provisional counting, they're very close to the final figures. So, and what proves that, there's a 69,200 there in dark blue, and that's in what was shown to you earlier. And we can consider that as the final figures for mortality with COVID as the cause. So I'm going to just keep one curve, or you won't understand anything of what I'm trying to show here. This is a provisional counting on death certificates that have COVID mentioned on them. Now, what should I add to this graph now? Just the excess data, excess mortality data. You saw that INSEE presentation earlier in Santé Publique France to understand what excess death is. Excess deaths are, it doesn't say what people have died from, but it compares the number of deaths expected to the number of deaths observed. And you realize then that something slightly abnormal took place. So if we take the excess mortality curve, that's INSEE, I could have gone with the one we saw earlier with similar data, but I just don't want to make this too complicated to understand. So here are messages that are quite similar. In April, 020 plus 57,000 data based on the excess death data. So you can see the COVID deaths. There's a variance there. It's not the same thing as counting the additional number of deaths as opposed to counting the number of deaths related to COVID for several reasons. But here overall, you can see that the main waves, the big waves, you see them here, but the figures aren't quite as easily superimposed as earlier. Because again, here you have excess deaths due to COVID. It's not the same, and COVID deaths is not the same thing because the effects go in both directions. As we saw, mortality for other causes was lower in 020 than it was in the previous years, and this explains that excess mortality in a total is lower than COVID deaths. That's 20,000 you see, 57,000 compared to 76,000 COVID deaths in 2020. Similar effect in 2021. However, in 2022, we have the opposite effect. Now, and that's the publication that Natalie wrote about 2 weeks ago, came out about 2 weeks ago. It's the fact that in 2022, well, the excess death as measured by INSEE was higher, slightly higher than the COVID deaths because, well, we've got some ideas. You had flu that in both spring and winter, which was quite strong. And then there are the heat waves in the summer and maybe something else, but we'll need to wait to get all of the data from the CPDC.
Je dirais que l'analyse.
So as a conclusion, I would say that the analysis of mortality related to COVID is based on an assembly of many different sources that existed but weren't statistically specific for COVID, sources that were a bit transferred and used. That's CIVIC, and that was following terrorist attacks. And who would have thought that that could be transferred to that use? And something that came together in just over a few weeks with SMS, and we hope that it will continue to be rolled out, continue to be deployed, and that's electronic death certificates. A very rich source, but less responsive is the analysis of all of the death certificates. So all of these sources don't say exactly the same thing, but they do. They are complementary. You'll see then that they are consistent. So that's reassuring, I think, right? Consistency that I showed you is reassuring, but that may not always be the case to be applied to every type of crisis. There was a lot of this that occurred in hospitals and establishments. Easier to see what's going on in hospitals as opposed to things that are going on at home, as we saw following the heat wave in the extreme heat wave in 2003. So we have different data when a lot of things take place at home. It also makes communication a bit difficult here because the ministry, SPF, INSEE, everyone was queried, everyone had different numbers. It's very difficult to aggregate those numbers, but then you can explain that in a crisis period, things are a bit more complicated. And now thank you for listening. Wait. A couple of points in the last slide here on where can we find all of this data. So all-cause mortality analysis, that's INSEE, and Santé Publique France. The actual data is available in open data and updated frequently, even today. So you can definitely track those. You can follow those. And also CIVIC and SMS. And if you want to go further, there's a DRESS method document there that gives you the difference of these sources in detail. So you're definitely welcome to check that out on the DRESS website. Thank you.
Merci beaucoup.
Thank you very much. That was very clear, very interesting. Let me first of all hand over to people listening online. There are questions coming in. We have a question. I think you answered it already during your presentation, but it gave rise to lots of discussion and debate during the COVID crisis. It might be for Zina's team. It's how were COVID deaths coded or diagnosed coming from the hospitals? Okay, it's quite simple. Hospitals, it was COVID plus. Could these COVID plus patients not have died from something else? So how was it coded? How was it diagnosed? And what was the sort of like this decision-making tree, as it were, as to, okay, this is a death due to COVID, or this is a death that's due to a terminal phase of cancer? How was that all sorted out? I can't answer for all of them, and if I say something wrong, you can definitely let me know. I think it really depends on the source, and that's what makes things more complicated. If it's a CIVIC source, then it will depend on the information that was given to the doctors, and that sort of evolved over time. In the beginning, You would key into the app all the deaths of patients who had COVID, and then we began distinguishing those, and that impacted the data. Now, the provisional data at the CEPI-10, the fact that it had COVID on it and it wasn't necessarily negative, that was enough to identify cause and effect there, including that as a death potentially related to COVID. So that was the provisional data available 4 months later. And then finally, for the final data, that's the WHO rules that were applied and the hierarchy across the causes. I think I'd like Ziad or Diane to answer that. Well, as regarding coding, if there was COVID on the death certificate, I'm assuming it's like, what if you had COVID plus other pathologies? Other pathologies. So it's, we would apply the WHO rules, and that was given in an emergency setting as soon as the COVID situation broke, and more specific information there. But I would say overall, the rules that applied to flu applied to COVID as well, aside from a few exceptions. Which means that overall, nothing could, say, provoke COVID or flu. It was if there was COVID on the certificate, but it ends up being the initial cause. It could be something else. But you wouldn't include the new pathology as the initial cause, which means it made things a bit complicated to track. That's true. The WHO rules exist because, as someone said earlier, these exist within the santé publique public health objective. So the first problem with COVID was to track COVID-related mortality rates and not lose those as numbers. That's why the rules exist. Same for cancer, same for dementia, and certain types of dementia, falls amongst older people. So there are very specific rules for those deaths.
Et des exceptions.
And of course, there are exceptions too. So I think there was nothing like COVID. If there's a road accident, that's an external cause, but that's easy to understand. Somebody has COVID and is involved in a road accident. The road accident is not related to the COVID. And so somebody who's in a road accident and they're pregnant, their death won't be linked to their pregnancy. And so there's nothing else that can provide for an external cause.
Je répète pour que les personnes en ligne puissent répondre.
So I'll give you another example. If somebody has cancer and then gets COVID, so depending on where the COVID is noted, if in the morbid process your COVID is listed on line C, the last line of the death certificate, and then B, there's COVID, and then respiratory arrest is line A, the initial cause for the certificate will be COVID. That's the rule. So cancer contributes to the fact that the person got COVID and that they died of COVID, but it's not because somebody has cancer. According to, well, in any event, and she didn't finish her sentence, but those are the rules. So I hope I answered your question. It was an online question. I think that you've given us quite a few answers in your response, but if a definition of COVID is not just unique, and so you have to be able to stick to international rules and have a common basis for comparison if you want to compare between the different countries, which now leads us to the next subject of today's discussion, which is the international outlook. So we have Jean-Marie Robin, who is from INSERM, And he will be telling us about comparisons between the different countries and how that was done. And so the floor is yours. Thank you very much. So I have been in charge of looking to see what happened and what we did in France. And so, once again, any opinion expressed is totally independent. And I have no vested interest or conflict of interest to declare with the topic presented. So now that the formalities are out of the way, I think I'm on tack. So there's the sentence. I will be talking about international experience, and this is from the right from the beginning. We set up a base on deaths caused by COVID-19, and there were about 20 or so countries that belonged to the OECD and who were monitored throughout the pandemic. These are the 21 countries that you can see on the map here. And so we monitored these countries very vigilantly, very closely. So there was the United States and Canada, and then all the countries around France, moving clockwise. There was England, Wales, Scotland, Norway, Sweden, Denmark, Holland, Belgium, Germany, Switzerland, Austria, France, of course. We were in the middle. Italy, Spain, and Portugal to the south, and to the east there was Moldavia, Romania, and Ukraine. And to the east there was South Korea and Japan. And so all OECD countries. And the aim of the presentation was to answer three questions. So what monitoring, how was mortality data collected, and what monitoring system was set up in the 21 countries? How long did it take to implement measures and to publish data, etc.? And what were the strengths and the weaknesses of these organizations? In terms of the materials and methods, there were metadata information sheets that were compiled, and I'll give an example of a metadata sheet or metadata record that was used for England. And what we did here is we tried to describe and qualify all the data that was made available. So there were several sections. There was coverage, collection method, circulation method, and so there was a lot of information on how much time it took. And so in terms of the results, so first I will present the general outcomes. So most countries had at least 2 monitoring agencies or agencies counting deaths. So most of the time, it was a public healthcare agency or directly in the Ministry of Health who directly counted and published the total number of deaths on a daily basis. And this was, of course, just limited to the number of deaths. And most often, the agency responsible for centralizing and coding death certificates also published weekly reports on deaths in which COVID-19 was mentioned as a contributing cause. These weekly reports, based on death certificates, generally provided information on the gender and age of the deceased, as well as their place of death. It should be noted that in the United States, the daily death count was carried out by Johns Hopkins University on its own initiative, and this was an exception. This was the only place where it happens. The initial daily reports generally became weekly reports after having been published only from Monday or from Tuesday to Friday. And so taking this a step further, there were certain countries that had systems for monitoring infectious diseases, which were well established and existed before COVID-19. So there was countries such as Denmark, Norway, and Sweden who had such systems. And these 3 countries had a national population register in which all changes in marital status, including death, are reported, as well as an information system connected to all the biology laboratories. And so the choice was made to count mortality occurring in the 30 days. So sometimes it was within 28 days, but occurring in the 30 days following a positive screening test for COVID-19. The principle was very simple. They cross-referenced positive test results with the population register. And that way they had an immediate indication as to whether people who had been tested positive had died within the 30 days following the test or not. So this system was implemented as of the end of March in Denmark, as of the 15th of April in Norway, and the 1st of April in Sweden. So generally speaking, you need a period to set up the system, and you need to break in the system, which took place during March and April. But by mid-April, or the end of April, most of the systems were stable. So there were 3 agencies involved, the names of which I've mentioned. And in Sweden, that's the most well-known one. It was the SMINIT network. All the biological labs are linked to this network. And in Norway, they have an equivalence system called MCIS. And then there were those countries who had a centralized system for dealing with death certificates and their codification. So the 3 examples I've used have been England, Wales, Scotland, and the US. It should be noted that in these countries, death certificates are coded as they are received by the central agency, and that the majority of certificates are received within 2 weeks of death, with the figures being considered consolidated after 4 weeks. So the choice was made to count mortality through the mention of COVID-19 on the death certificate as either the main or the associated contributing cause. Its implementation generally took place in April. In the United States, it was up and running from the 15th of April. And then I've mentioned all the agencies. So there was the ONS in England, or the National Center for Health Statistics in the United States. So there were countries that had 2 counting systems, counting mortality within 30 days of having tested positive and causes of death. So these were countries such as Denmark, Norway, and Sweden, which had these 2 methods of counting. There was the first count of mortality within the 30 days following a positive test for COVID, which was generally published daily, and a count of death certificates with mention of COVID-19, which was generally published weekly. We were able to compare the 2 counts and possibly correct one another. And so this happened often. And so sometimes we would say, for example, every Wednesday or Thursday, when the report based on death certificates would come in, there was a correction that was made to the other system. And so the daily information that had been based on the test was then corrected on the basis of the new report received every Wednesday or every Thursday. And for the countries that didn't have either of these systems, which had been established before the pandemic, so this was generally all the other countries, they set up information systems on hospital mortality due to COVID-19. So, for example, in France, we just heard about Civic. And sometimes, which was quite rare, on mortality in homes for the elderly. So there was an example in Spain. And they generally published figures only for those cases of COVID that had been tested in the laboratory. So that was as of the end of April 2020. It took some time to set up the system. At first, there were a few hiccups, and they had some redundancies and double counting in Spain. They had a system that would count all the deaths, and then they had another system which would count all the deaths occurring in hospital, and instead of reconciling, they added the 2 together. And so in general, these countries did not communicate where the deaths occurred, so the place of death. Then there were the countries without well-established surveillance or monitoring systems. Generally speaking, the information, the flagging of information was complicated. Generally, it was passed on to the Ministry of Health or the Public Health Agency in a fairly complex process with local centralization, and then was sent out to the regional level and finally centralized at the national level. This was set up in Germany, Spain, Italy, and Japan, for example. In some of the cases, the information was checked by the ministry or the national agency before publication. But it's feared that the fact that the circuits for communicating information was so complicated that it led to delays in epidemic surveillance and delays in the publication of the figures, and that there was a certain amount of information lost. So in conclusion, very quickly, the most salient points. So in the absence of rapid centralization and coding of death certificates, there is no information on the place of death. Often only hospital deaths were properly identified. And this was more worrying given that there were concerns related to old age homes. All the countries studied published figures, but there was a great deal of confusion when it came to setting up emergency systems. And so there were many gray areas. There were two systems that appeared to be effective and unbiased. One, surveillance monitoring of infectious diseases using all the country's biological laboratories, and rapid centralization and coding of death certificates. So these were two approaches that were complementary to each other. The first enabled daily monitoring and quick reactions. The second was a slower one, but provided for information necessary to adopt suitable actions and based on gender, age, the population, or the territory concerned. So these two systems need to be well established when the pandemic arises. So computerization is important and should be a major help, including for a population register, bringing together all civil status information. And so specific conclusions are that some countries were very responsive and very transparent, even despite the hiccups, such as in Spain, where they owned their mistakes, they explained their mistakes. For some of the other countries, it was difficult to collect metadata, and so some of this data remained, unfortunately, incomplete right through to the end. Some countries were very rigorous and stable in their communications, allowing automated data collection. And so they're still collecting data every day. Nothing's changed since the end of April. And some countries were very reluctant to publish their information, such as the National Center of Health Statistics in the United States concerning the race of the deceased, when the information suggested that there was a very high mortality rate in certain population groupings, and notably amongst the Black American population. So there were quite a few publications on the basis of the worst work. There were articles published by the members of the database, but the database was also used as a basis for other articles that were published. About 100 or so scientific articles were published and quoted and cited in several articles. And all the references can be found here on the address provided. And the database is still available if you are interested. So here are all the publications, and this is the link whereby you'll be able to find about 100 or so articles relative to the space. And this is a base that is still up and available. It's still available, and when you click on it, you can find all the data and metadata records available both in French and English, divided country by country, or pulled together. So thank you very much for listening to me. Thank you, Jean-Marie. That was extremely interesting, and it enables us to put everything that we've done into perspective, as well to see what the others have done as well, and to see where we stand. When you speak about pre-existing monitoring systems, which was something that was positive, it was a virological monitoring. So they use information coming from the laboratories. Yes. Does anybody have questions from our audience? We do have one question. And so the monitoring system with the laboratories, what was the status of the labs? And are they part of the public healthcare system, or were they private laboratories? I don't quite know. I hadn't actually planned for your question. But in all the metadata that I'd read through, I wasn't the one that collected them, right? I collected all the metadata, and very often they speak about labs with type approval, authorized labs. So there was a system to type-approve the labs, and they would then participate in the monitoring network and in the data collection. So I couldn't tell you whether SMINET in Sweden, upon the initiative of the Swedish government or upon the initiative of the labs, whether it was put together on all those initiatives or if or how they came about. But in any event, in all countries that had these monitoring systems, they made use of data coming out of all the labs. All the labs had received a type approval to contribute to provision of this data. And what also helped was having a national population register, and there was a correlation. INSEE collects data relative to civil status, and so this is available for everybody. And so there was all data which helped in the monitoring. So if people were tested as having as being positive to COVID, it was easy to track and see whether they died within the next 30 days because of all the data systems that exist. So hi, I'm from Santé Publique France, and I have a question relative to your feedback or return on experience. Were there any countries that had systems that didn't prove to be effective? And did Europe or the European Commission try to standardize methods or to try and propose systems that were more responsive and that were better adapted? Well, we don't have information on that. And we didn't look to know. We don't know whether the European Commission had instituted any measures to accelerate transformation or institute any changes to ineffective systems. So unfortunately, I cannot answer your question, but maybe somebody else from Santé Publique France can give you an answer. Maybe I have knowledge within Santé Publique France, but I don't have that knowledge. I can only tell you what we observed abroad. And what we've seen, and it was mainly the English-speaking countries and those in the north of Europe, they already had pre-existing systems, and their systems were a lot sturdier and a lot more robust than the systems that we had seen or observed elsewhere. So thank you very much. And so this brings us to the very last round of presentations for this afternoon. And this will be Anne Fouillet.
Qui fait le lien avec la question.
How can we do better? And what will be the contribution of electronic death certification? So François and Céline explained that to you, and we heard some really interesting information about that. Our system was really good. We had good results, so quite encouraging, but there were some limits. And first of all, what we said, it was the lack of visibility on the deaths in the home and on the public highway. François illustrated that, limited impact for COVID-19, because it could be even more problematic for other situations or events that are more, that impact more in-home mortality. Second point, we said that on several occasions, the additional burden of specific systems for HCPs, systematically having to fill out the death certificates, and then you had the civic system and the SMS system that didn't allow for the compilation of additional complementary medical information on the deceased. We were sort of navigating blindly as regards to comorbidities and determining exactly whether it was COVID. And then finally, a lot hasn't been said about this, but we did track COVID mortality, but we were unable to track the impact of other events that could have occurred simultaneously. So we talked a lot about mental health and effects on suicide, for instance, but there were impacts on mortality related to the epidemic that could have taken place over the past 3 years. And a lot of questioning on the increase of other types of cause of death during confinement, during lockdown. So that meant certain limits, and the electronic certification of death was an existing long-term tool that could address a lot of these limitations. The transmission of data from the medical section could happen within the minutes or the hours following the validation of the certificate. There could be some changes in the following 96 hours. You have a responsive analysis of the cause of death, and that meant some 40% of the deaths certified electronically nationwide. You can see that on the map. A lack of uniformity across the territory there. We saw this earlier, essentially rolled out in hospitals, and it's still increasing with it becoming compulsory as of June 2022, but still insufficient in the home and to a certain extent in the retirement homes. And they also are impacted by the compulsory certification as of June 2022. So now, to find a solution for the limits I just mentioned, we need extended rollout in the future of the electronic certification. Now, the medical causes of death, and now this being made digital, this means it's available very fast, and you can get this in a free setting. So this means we have to develop algorithms to recognize words or expressions. It's a bit different than just say COVID causes. And they don't have the initial cause because that's determined much later during the coding stages. So Francois illustrated this. There's an algorithm that was set up as of March 2020 to identify deaths with a mention of COVID. At the same time, we're developing other algorithms to track other causes, such as other simultaneous health events, but also following trends of the major causes that can be indirect or indirect impacts of the comorbidities of the events there. So as an example here, you have the simultaneous monitoring of influenza and COVID. And here's in December 2021. Here's the This is published every week in the winter periods, and then you have that where influenza or flu is mentioned. So this is not in electronic certification. It's not exhaustive, but here it's not having a very specific, very precise count of the death certificates. But what we're looking for here is really to have the momentum of the epidemic and the mortality related to influenza through this source. And here we can see, maybe not present here, but the dynamic, the momentum, the dynamics here on the death certificates is consistent. Second example is the algorithm that we developed with the CPD-10 and CPD, and this is here the graph you can see is the number of deaths expected, and this is all certificates coming in over 4 months' time, and the electronic ones that come in right away, plus those that come in between times. But this is on free text written in on the death certificate, so we can see very quickly that there was a decrease of mortality with the suicide during COVID, during lockdown, for COVID during lockdown. And we didn't, in fact, we weren't exposing this with the, of course, the caution that we were using on the new forms of certificates, but we were exposing an increase. We did expose an increase in mortality due to suicide during COVID. This gives you information on the matter of indirect impact during an epidemic. So this, of course, is something difficult to implement routinely on the electronic certificate because it's not used usually in the home, but then you would have see this ratcheting up. We can roll this out more generally speaking. So here's a summary of certification. I'm talking about reactive monitoring. That would mean a single document for the health care professionals to fill in for official statistics, research, international affairs, of course, everything that we can do here. So electronic certification then provides improved coverage of deaths by cause. We heard this earlier by Liz. This means you sometimes have certificates that get lost if they're in the snail mail. So this means we get a more accurate report of the causes of death. I believe Zina mentioned that. We'll have a module to assist in certification to limit ambiguities in the words. So we would then promote automatic coding and more accurate and precise information. This hasn't been mentioned yet, but this is a way of interacting with the doctors, with the certifying doctors, to provide additional information on an occasional basis, of course, in certain situations. And then subject to wider deployment of electronic certification, this would be very useful for authorities and decision makers, be it national or regional health agencies, to have the information trend analysis of the impacts in crisis situation, but also you have the indirect and direct information to support decision making, analysis for other causes. This also allows them to have coded data and being able to monitor the trends in certain causes, and then contributing to the evaluation of prevention plans, the rolling out of prevention plans in certain cancer, suicide, falls, and so on and so forth. Of course, there can be other improvements. We talked about electronic certification, but there are other systems that compile information on mortality can see improvements as well in the future. Specifically, you can talk about 2 projects here, and that's the matching of INSEE data with the data by cause from the CEPIDIC using common identifier, and then the CNAM data to have additional information on deceased patients. That's it. So those are some ideas and projects that we're working on and things that we can discuss.
Est-ce que vous avez des questions pour Anne?
Any questions for Anne?
Est-ce qu'on a une question dans le chat?
See if there are any questions in the chat. How can you track infections such as VRS, and it's a respiratory viral syndrome, syncytial respiratory virus? Well, there again, that could be tracking mortality with the words on that, but you have to include that in the codes and the words and what the doctors write on the death certificates. But I think they rarely see SVS. But you have bronchiolitis. We have a lot of deaths due to bronchiolitis. But these are terms and expressions that we could set up algorithms for those to implement monitoring. This is what we might be doing as of next winter. A question.
Moi, c'est une question plus, pardon.
Well, my question, Guillaume, doctor in SPF, this is more about hacking. During COVID, there was a lot of hacking. And I was just wondering if the electronic certificate, could it be hacked? Have you thought about cybersecurity regarding that? Well, at any rate, by implementing the electronic certification platform, everything is certified, authorized. It has all of these security standards applied to it. But what's confidential in the death certificate are the medical causes. So what it says on the format of the certification, you have that upper part and with the name and with the names, but then the bottom part you don't. So in the electronic certification, you have the same situation, meaning the information circuit is broken up, so it gets straight to anonymous data. Meaning it's the same rationale. Once it's signed off on by the doctor, then you separate the data. It's not on the same page, as it were. Of course, the risk is higher, though. because you don't have to go around to all of the city halls and the regional health centers, regional health agencies to pick up the documents. So yeah, the risk is a bit greater. But all safety measures will be taken, all security measures will be taken. Now, could we perhaps illustrate with some recent examples for electronic death certificates? If we look at some causes that can occur simultaneously, because you saw, we had some, we had the monkeypox, so we had the respiratory illnesses, we had streptococcus A, other concomitant occurrences that could be perhaps included by the electronic, and maybe some sensitive sort of deaths where we had like children who died, and that way we could sort of cross-check the data and get confirmation. Now, during COVID, we systematically had all the deaths that were identified amongst children, either declared in civic or by electronic certification, and getting feedback from the doctor to validate that connection there, and the connection with COVID. Was COVID really connected there? Is it mentioned on the death certificate or not? And so this way we could validate and then correct where needed, correct these certificates if sometimes there was a mistake in the date of birth, and so the doctor could correct and add some additional comments. So it's quite practical as well, because it's much more responsive, much more reactive. As Diane and Nina were saying, getting back in touch with the doctor is complicated when it's many months later. Plus, it's hard to verify as well. So in some cases, there can be a very sensitive situation. So it can be interesting to have that reactivity in the analysis, and for certain very specific pathologies, be they very severe or rare, or amongst, say, very sensitive populations.
Jean-Marie, je te donne le micro.
Jean-Louis, handing the mic over. I wanted to say the long time it takes for the paper certificates to make their way, and to make their way up. In fact, that's in other countries as well. But many countries have already simplified the pathway here. I heard several times today that paper certificates sometimes went through the regional health agencies, and a long and sinuous road before they made it to where they're supposed to be. It could take weeks or months. Is there not a possibility to simplify that? And then I think that during the pandemic, at least the first 2 years anyway, I think that the CPDC only published information once they received some 90% of not the death certificates, but maybe the death notices by the INSEE. So it's a bit of a ratio there, I believe. But is that ratio maybe not too high? Is there not a way to ... Because I have the impression, and like in the U.S., for instance, they've mentioned the same problem, because the information goes from state to state. And some of the states get it done very quickly, and other states take a lot more time. So they do consider that after a month's time, they should have consolidated information, consolidated data. And so that's just my question. Is there not a way, is there not a solution to simplify this if there's some resistance to the electronic certification? Oh, first point, in the U.S., there's 100% electronic certification. The only regions would be outside the government. So it's much simpler, so they don't have that time lag. Another point is in 2020, you had 20% of electronic certification in France, so it was quite a different situation then. And then another important point is to keep in mind that deaths are completely different. Deaths on paper in homes are completely different from deaths in a hospital setting. So, of course, with COVID, everyone died in the hospital. That really didn't change the situation much. But if okay, you're bringing the information with some, once you have 90% of the data collected 4 months later, you don't get reactive indicators immediately. So, but it can confirm them. You can verify them. Even 4 months later, you look at what happened in March 2020, I believe. Of course, yeah, that was important though. But let me also pick up on a point, a comment. It's a comment and a question at the same time. It's what Anne said on algorithms to identify text. That's really powerful. You know, we all know we have purposes that are different, you know, from this health, public health and epidemiological data for comparison purposes on an international scale, where it's really important to apply coding rules that are identical. That's the coding of a cause and cause of death. And then we have a need for immediate reactivity. Like in the pandemics, for instance, we came up with a solution when deaths occurred in hospital settings, but now we need to expand that. If we've got, say, a little less responsiveness, you can't get it right away, but you have to have a solution that's applicable to other causes of death. And I really believe in using just plain text, raw text, and the death certificates and algorithms can pick that up and target things that are very apparent, and that the doctors will want to and need to specify in the death certificates. And I think that's really important for a reactive analysis. And you have to keep in mind that even though Anne said that there was a big part of it that was just electronic death certificates that were used in the beginning of the crisis, now systematically, CPDC, once they get all of these certificates, be it paper or electronic, they make them available to Santé Publique France to carry out these analyses. You have to make sure that there's not too much of a time lag, and at some point, if there's a crisis starting, you have time frames and you have deadlines, but you can still compare 4 months later, just like you would compare reactive indicators on a given period, especially right at the beginning.
I just wanted to add something, Sean. So a few years ago, when we participated in the US in a congress, the Americans were working on free field, whereas with us, we had coded data, and they wanted to keep it to a free-filling text. They said if the doctors wanted to identify something that was out of the ordinary, they needed to write it out in full. They needed to have a free field to insert text. And if we compare the two, the code doesn't always necessarily match if there is a specificity. And there are some things that can't be coded because either the code doesn't exist or it can be just so specific that you need a free field to write it out. And the same holds true for the morbidity analyses. And so we wanted to ask you a question, but we are running a bit late. And our initial idea when we kicked off with the session was to get your feedback. And the last presentation, we looked to see what is our outlook for the future. So we've seen the certificates and the application of the certificates and the way it was done during COVID with its strengths and its limitations. And our question is to you as professionals, health authorities, researchers, healthcare professionals and researchers. What did you feel was missing? What would you have liked? Was having to respond quickly, did it cause stress for you? There were certain questions that we wanted to hear from you on, and we won't have any time to go into detail today, but off the top of your head, in a wait of the system to change, whenever we're not confronted with a crisis, it always takes longer to change the system. But we'd like to know what measures should be taken, what levers or drivers should be pushed. Would anybody like to say something? I know we've gone way over time, but it's just proof of the fact of the level of interest in the subject and how we follow up on the way we register and record deaths. So, François? Well, when I was listening to the international perspective and international experience, I thought, okay, well, surely there's something that we can do. Our deaths are recorded by the INSEE, and this is done almost in real time. And then we also have many databases, many medical databases, and whereby we can trace and see for what somebody's being treated, what are the analyses that they've done, and how they're being treated. And this can be accessed almost in real time. And even during COVID, we weren't able to connect the two together. We tried to do a correlation between victims in hospitals or with their vaccinations or their screening, but we never correlated with the deaths. And we didn't register all the deaths in the system we used to follow up on COVID, and that system was always kept separately. And yet we had the means to do so thanks to all the data we've spoken about today. And so if we could have all the data from the SNDS in real time, enriched with the data from DC, I think we would settle the problem. We wouldn't find the entire solution, but we could solve many of our issues. And I think in terms of what was done in the Scandinavian countries, they were able to get their hands on the lab analysis and the cause of death. And in terms of the laboratory analyses, we get those via the CDEP. We knew who was vaccinated, those who were being admitted to hospital, and even those who were in ICU, but we weren't able to see who had died thereafter. And so I'm pretty sure that there's something that should absolutely be done. We've made a lot of progress with the introduction of digital means, electronic means, but I think that this is also something we could envisage to have a better system the next time around, in the hope that the type of thing won't happen again. Unfortunately, the comment is being made off mic. And so I think what's missing is the availability of data to research organizations. I'm thinking in terms of CDEP, there were certain bodies that if they had this information, they could have done studies that would be interesting for everybody and useful on COVID. And at INSEM, for example, we don't have access to all the data in the SNDS. And just to be transparent, in terms of accessibility of data, all those who are involved in public health should have access to the same data in order to do what's best. Does anybody have any other comments before we conclude? All right, well then I think the time has come to conclude, Bernadette. So I wanted to thank all our speakers today and all those who are involved in preparing the session with the speakers. The session really covered many aspects of the topic, right from the design through to monitoring to how we do surveillance of mortality in France as well as what happens abroad. I'm pretty sure that all of you will go back to your unit, your department, with some food for thought and ideas on how we can work together and further our collaboration. So thank you to each and every one of you, and enjoy the rest of your evening. And we will see you next year for the next edition. Thank you, everybody, for attending and for your active participation.